Hi, folks. I'm Adam Mariano, President and GM of the Healthcare Division of LexisNexis Risk Solutions, and this is our podcast, Healthcare Data Lake. We know that the American healthcare system struggles to serve everybody equally, and it's often difficult for folks to navigate this fragmented and really ever changing operating system that powers healthcare. Like a ship on the water, we all generate a bow wave and a stern wake of data, the trail that we cut and leave through the healthcare system. This podcast is about people finding better ways to leverage this data and to better serve patients and their families as they make this difficult journey. My guest today is Damion Nero, head of science at US Medical at Takeda, a top 20 pharmaceutical company. And hey, Damion, really glad to have you here today. Um, will you share a little bit about your journey and the critical focus of your role at Takeda?
Sure. And thank you for having me, Adam. See, as head of data science, a lot of my focus is on sort of advancing our research pipeline and providing resources and support to a lot of our researchers, mainly in the medical affairs, sort of traditional HUR, RWE research space, but also to our clinical and even to a certain extent our commercial teams, although I have some very strong counterparts there. A lot of our focus now is trying to shift the narrative, both from a perspective of being more patient focused and really understanding the patient journey, as well as to try to incorporate some of the new techniques and data sources that are coming onto the market and that are really giving us deeper insights into our patient communities.
So, Damien, your role is sort of like in the sweet spot of what we like to talk about. It's sort of this nexus of technology, healthcare research, and then the realities that patients are engaging in ever greater digital experiences within healthcare. And you and I talked a bit prior about how the shifting landscape is leaning more and more in the DTC direction. So for those out there not familiar, direct to consumer, where we're not necessarily asking patients to go to clinical research centers or to their doctor to engage in the clinical trial. And they may start there, but we're asking them really to engage directly with manufacturers and research institutions to have a more flexible, easier to consume, sometimes experience that fits into their regular daily lives. And I'm sure a big chunk of your job is around trying to figure out how to get these things to work more efficiently, but also pragmatically, given that this is a huge pivot for an industry that's always relied on endpoints being at health systems. What do you think some of the early barriers have been to this process? Like, what have you seen?
Well, I mean, just speaking generally for the industry, I think that the biggest barrier is that people don't understand is that the system that exists by design. There are a lot of people who make a lot of money as intermediaries in all of this. The direct to consumer model cuts all of them out. It's not just the HCPs that would probably have less influence on what patients take. It's also the pharmacy benefit managers who profit greatly from this industry. It's also the insurance payers who do, even though they are paying out for these drugs, by having that coverage be part of the plans that they offer, do profit from this. And there's over dozens of others, everything from acute care facilities to other types of organizations who, again, they need to be paid out some way, shape, or form throughout this process. Direct to consumer literally takes it from us to the patient, from pharma to directly to the patient. So that is going to be a challenge because at some point you're going to have either legislation that tries to block this, or you're going to need legislation that allows this to happen. And one or the other is going to have lobbyists and other special interests pushing for the existing system to stay. And so that has always been sort of the barrier to this kind of change. I do see momentum in this direction, and with companies like Pfizer and Lilly taking the lead on this, I think that there's definitely promise in doing it. I think it's something that is necessary to democratize medicine. Much of the time, our drugs don't make it to patients because there are all of these barriers. Ultimately, it drives up costs. It creates inefficiencies in distribution. There are restrictions on, what can and can't be given. It's not just from the FDA. It's of the whole formulary tier system and other sort of constraints around how drugs are delivered to patients. I mean, is there a pharmacy nearby? Are they able to get to the right facility to get the prescription from the right doctor? All of these things need to change in order for patients to be treated better, especially considering the fact that disease is becoming more complex. And we're seeing a resurgence of disease we haven't seen in years. Measles is making a comeback. So is, things like, whooping cough. I mean, things that we have thought we had effectively cured, at least in the industrialized nations, are now coming back in full force because of a lot of policy issues and also misunderstandings among, so the patients around what is really effective therapy versus what is dangerous to them. So it's many challenges that I foresee, but definitely something that we are engaged to deal with and are very interested in see move forward.
Well, you hit on a ton of points. So I'll break some of that down and talk through it a little bit. Um, the big one is democratizing a process that was never democratized, right? And when we've watched this through all sorts of technology hurdles, process bumps, delivery mechanism changes across multiple industries. This isn't specific to healthcare. Healthcare is always a little bit behind the curve. You know, we all estimate what 5, 7, 10 years behind rest of the marketplace, but there's an easy analog in banking. I grew up where my mom used to make me go with her to the bank, and we would have to go inside the bank or wait outside by one of those tubes where she wrote a paper check and
Mhm.
went up into the bank and it came back out. And we cut out all of the bankers with online banking, right?
Mhm.
And there was all the things you point to, right? You're going to have to pass legislation. There's going to be lobbyists against it. There's going to be lobbyists for it. There's process change. There's the community who you're targeting has to adapt to it, right? They've got to adopt whatever is coming. So, from the advent of ATMs to online banking to the fact that you can now not even bother to deposit a check and you could just take a picture of it and the
Mhm.
check just gets thrown in the garbage, which is why shred them, but it's a different conversation.
Sure.
Um, in the clinical trials and clinical research space, you make all the points that there's just a huge array of people who have to change their approach to this in order for this to become the ubiquitous model. And
Mhm.
it's gonna face a lot of headwinds, and quite frankly, there's probably some things that just don't fit well into this. So high complexity stuff, things that require a lot of clinical care to
Mhm.
execute, lots of the device things that actually have to happen in a clinical setting.
Yes.
But for all of the other studies that this makes sense for, what do you think the baby steps are, the kind of things that get us there a little faster? What do you think the critical focuses might be? You know, think 25, 26, 27. Like over the next, I'm gonna put you on the spot, 36 months. What should we be focused on, right, to really make this better?
Well, I mean, so I think you're getting at two sides of this. So one is the development process, which also has to undergo some of these changes, and we're doing
Mhm.
that already. Decentralized trials is a model that is becoming much more popular. Now, to define that, basically, it's trials that don't rely on you necessarily bringing patients into a facility. That everything doesn't have to be around some sort of centralized system where everybody has to come in multiple times to just participate in the trial. We are now moving a lot of that to electronic mechanisms of data collection. We're using telehealth in order to have, sort of HCPs check in with patients, understand symptoms, things like that. And I see that accelerating, especially with AI coming more online and biometrics getting far better. I mean, wearables, I mean, it's not just, things like an Apple Watch. There are other things that are really providing real-time diagnostics on patients that make this model far more easier to adapt. So I see that just accelerating over time and really becoming sort of a mainstay. We've already kind of fought that battle to a certain extent, and so I don't see as much pushback there. I see it kind of having good momentum without a lot of blockages there because that part of the industry we do control. Ultimately, we control how we decide to run our trials and how we want to do these things. And frankly speaking, it's cost prohibitive to try to keep the centralized model more than we have to because it's difficult to recruit patients, it's difficult to retain them. And so really this provides a lot more flexibility there. So I think that's a battle that we're well on our way to winning. Now, the other side of that is again getting back to my earlier points and and just try to move that bar forward. Again, the bigger players doing this already is great, but they tend to kind of run hot and cold. If it doesn't show immediate results, they'll go back to the original model just by
Mhm.
default. And there may be some kind of going back and forth. That's what I see over the next few years, unless this really takes off. What will happen is that okay, they'll try this, they'll get pushback, or they won't, do as much in sales, and so they'll say, "Fine, we'll go back through it," or they'll get pushback from bigger partners that we have that frankly, this kind of sidesteps them, and they're not going to be happy about that. And rather than damage those relationships, they may pull back because of that as well.
Do you think that there is an incentive model that we need to start thinking about to sort of break some of that behavior? So
Absolutely, but I don't know how you incentivize the people you're going to be cutting out. I mean, There was a point where there were companies that just made whips for horse and buggy carts. There were companies that made wheels for those carts, but then you had cars come in and they all disappeared. There was no
Yep.
incentive to keep them. There was no way of them converting their business model in some cases. They just disappeared. That is what we're facing, not just in our industry, but many others, where they will just disappear. They're going to fight existentially to exist, but ultimately they won't be able to in the new environment. So it's an unfortunate thing, but these kinds of shifts happen. And we can try to soften the blow. There'll always be, to your point, areas where this doesn't make sense to move into direct to consumer. I mean, there are infusions, for example, devices that have to be implanted, in medical settings where yes, there's not going to be a really a lot of consumer choice, even if we wanted to provide it, because there's no mechanism to do so. So I think that it'll be a slow kind of move away from this, but that will take time. I mean, the 2 to 3 year window, no, but 5 to 10 years, yeah, you're going to start
Yeah.
to see some portion of this industry disappear, or having to adapt to become something else.
So, Damien, as we think about the more direct to consumer model in its expansive form, it's a data hungry process.
Yes.
And a lot of historical research data is aggregated, right? It tends to be de-identified aggregated data.
Hmm.
And more so as we get into real world data, we're really interrogating sources that offer us data at an individual level. So
Hmm.
Adam's EMR data gets tokenized, so it gets de-identified, and then it gets linked to the research record, and we use that
Hmm.
to look at episodes of care, the kind of care pattern, what happened prior to me getting diagnosed, what were my outcomes post-diagnosis. What are your thoughts there? What are the critical kind of data sets we need to be looking at to start to integrate this at a patient level in order to make this kind of work more successful?
From that perspective, I think we have made, at least, aside from companies that are just data hungry in general, a stronger push for data like SDOH, for example, for genomics data, other data sources that are becoming more prominent right now to better understand patients, their journey, and their underlying circumstances, which ultimately drive a lot of their healthcare decisions.
Yeah, I think you hit on a critical point. Social determinants and social drivers are, for those not aware, those are the obstacles to patients getting care, participating in studies that go beyond their diagnosis. And we found out research over many years now, they actually account for about 80% of outcomes versus the actual diagnosis, which when you realize how many folks don't use social determinants data, it's stunning, given they're so impactful to actual care delivery. In the research space, this feels like as we go down the hill to this model where you're looking at hybrid or direct to consumer studies, understanding the social landscape for patients is critical, especially because we seem to ignore the fact that a big chunk of the population still relies on prepaid data and flip phones and doesn't have broadband. And so a fully digital model for remote creates a problem, which means you have to rely on, to your point earlier, true traditional telehealth, telephony, um, kiosks at pharmacies, kiosks in a grocery store, going to a local community center like a school or some other endpoint that can actually be used as a data collection center for people who couldn't participate from, a traditional, we'll call them dumb phones. But there is that real reality that when you sort of do the overlap Venn for income and access, that's where the hole is, right?
And to your point, we will need tokenization to link that data to existing data that we're collecting, existing data for these patients or data that we're collecting as part of a trial. And it's been active efforts to do that. And I think that it's giving us a clearer picture of the overall patient, where they are in their life, as well as, their overall healthcare journey. And, just beyond that, even beyond the development process, we're also doing that, whether it be, sort of prospective studies, whether it be, sort of patient reported outcomes, things of that nature, pulling in that data, linking it together with other data sources, again, to create this sort of agglomeration of data that really gives us an overall view of the patient. We're trying, I think, slowly, but we're trying to move past looking at patients as just a collection of symptoms and rather as individuals who have nuances that go beyond just what they're presenting with. And how do we treat the individual? And this is, sort of the push behind precision medicine in the sense that, we need to kind of get past the idea that we can make one drug that was just going to work for everybody. We know
Mhm.
that, there are cases where patients don't respond to therapy, where they have bad reactions to therapy. this data helps us to kind of mitigate that by adjusting, everything from dosage, route of administrations to formulation in order to be able to get this therapy as effective as possible for sub cohorts within these populations that are different than the, larger population.
Well, I'm in love with the problem of of uh, digital and dialed in, really personalized medicine. And when we think about this, I love the idea of a personalized formula, right? Which is, and it's not really the direction we're going, but somewhere between a personalized formula and one size fits all is where this lands, where there are levers you can pull in order to make dosing and formulation and compilation pragmatic. But it's also, in some cases, we're literally spinning the patient's own blood or other components into a solution, which is about as personalized as it gets. But I think you hit on the critical point, which is being able to integrate the entire patient journey, depending on their environmental exposure, their age, their gender, their other conditions, where they're getting their care, the pragmatism of whether or not they can even tolerate a solution given their social infrastructure, which is one of the big things people don't even think about when we talk about a clinical trial or
Mhm,
a transplant. And there was this big article in the New York Times about people being bumped from the transplant list without, being pragmatic about the fact that, hey, uh, Adam and Damian might show up for the same transplant with the same problems, but
mhm,
maybe Damian has a better social network around him. You live in a place where you've got access to care, you've got family in your house, you've got transportation. You
mhm,
can likely survive the transplant process better because you have all the components of a stable social life versus me who's living on my boat in a marina somewhere, which I'm likely to do, and not have family around and be struggling, to get wherever I'm going because I'm getting there by scooter. I bought an electric scooter and that's my life.
mhm.
Um, and I will or will not, I will not confirm or deny that that life would appeal to me. But it is the thing that likely me in that situation where I'm isolated, I have poor transportation, might be in failing health, I'm not going to complete a study.
Yeah.
Right. I'm likely also going to struggle in the post care that's required for an organ transplant, and being able to stitch together my social situation plus my EMR or charge master data or my outcomes data, my PROs, the things that I think about my own care. To your point, they're going to be very different for you and I in that imagined scenario, and decisions get made. And as we talk about, I love everybody. Let's talk about care rationing. It's one of the reasons we don't do single payer,
Mhm.
but we do ration care, whether we want to talk about it or not. There's
Yeah.
only so many doses of a drug. We watch this with GLP-1s.
Mhm.
Um, the transplant list is just an never-ending problem of we only have so many organs to share, which is why we're trying to figure out if we can transplant pig and cow organs into people.
Mhm.
Um, it's not because we want to, it's because there's clearly a dearth. So, I think you're spot on there that this is the thing is the more data we can get in the space that tells the full contiguous story of a person, not a patient or a recipient or a study participant, but a true personhood, then you've got the ability to build personas into your treatment arcs to say, hey, Adam and Damien are not the same person all the way down to their feet, even though they're both coming from an African American community, even though they live in the same rough zip code.
Mhm.
You're on the western border, I'm on the eastern border, and maybe it's really different opportunities. Like I grew up on one side of the tracks on Long Island from the wealthy town down the hill. Town name was the same,
Yeah. It's
but
like
one part of that town had a very different reality than the other. And
whatever.
so, it is what it is. So I think there's a huge opportunity there as we start to think about integrating these sources and tokenizing them and getting them into regular usage, that there's an opportunity there for sure.
Absolutely, and I don't want people to think that this is science fiction. It's been done. The
It's
thing
been
is, we
done.
just can't scale it. There's a case several years ago with a little girl, 8 years old. She had a disease, rare disease, considered almost incurable. She had a mutation that made her disease not necessarily responsive to treatment, even for the treatment that existed for her, type of condition. So there was a monumental effort that involved Boston Children's Hospital, and genomicists and other people collecting data around her. They literally made a treatment that just worked on her. And she responded very quickly. She now lives an almost normal life where most people in condition we're barely able to keep them alive. That is the promise of precision medicine. And that's kind of what we're working towards. that costs millions to do, which is not sustainable or scalable. But with AI, the hope is that we can explore all of these possibilities far more quickly and come to solutions that are, in a way that's far more cheap, the low cost rather, to get these, to patients in a larger scale.
Yeah, especially if you don't have to carry out these physical experiments in real life, being able to iterate them and model is there. And the reality is, to your point, we sell this data, right? We have socio and EMR and other data sources that we integrate and put on a token. So it's not a lack of availability. I think it's a lack of process and change in orientation, which is your backbone and base needs to be an inclusive set so that you can actually work from a population and have an orientation to actually see the whole person as part of this conversation. I will ask the question that we've been asking at the end of all of these podcasts because we don't want to leave people here.
No.
If there was one thing you could change, we think it would be impactful, right? Today, right? And it can be a magic wish, but what's the thing you think this thing is the thing that I think it would be wildly impactful and I'd ask for if I had that power today?
Um, I would say that really, sort of moving more quickly towards a decentralized model, not just in terms of the direct to consumer model of distribution of our therapies and our drugs, but rather just in terms of how we do everything. I think as an industry, biopharma, biotech, we've always have felt this need to own everything, to, really have everything under our umbrella. But there are many communities across the world we'll never reach because of the fact that they don't have the infrastructure or they're not a big enough market to have us make that kind of commitment. I think we need to move towards a model where we engage them more to be our partners and in some cases our surrogates, whether that be through some kind of franchising sort of model or whether that be through private public partnerships, where we work with local governments, is with the Fiocruz model in Brazil that GSK did. There are many different modes of this, but it's what's necessary in order to really get our treatments to patients around the world that need it. And I think that's the only, path forward, frankly, because as supply chains fall apart, as governmental structures change, as the world changes, we really need to kind of rethink the globalization model that we've relied on because it just won't exist. And we're going to have to work around that if we're going to survive as an industry.
Well, I heard you say this before, and I would lean in here on the franchise model. I think, a multifaceted healthcare franchise model with different components and capabilities. I hate to say like McDonald's, but like McDonald's, right? A wildly successful model where you train a local operator, you give them some partnership from corporate support. In this case, could be public and private, could be governmental NGO. But the reality is you could start with care delivery, widen it to care research, widen it to training, and it could be a franchisable model that you could essentially establish a regional cost model for and then replicate it city to city, region to region, and to your point, well outside of the United States to other places that have struggled with rural and urban care as well. I'm behind it. You got at least one other vote.
Good to have some support anyways. It's a controversial idea, but I don't know. I'll keep preaching as long as I can.
I think it's probably less controversial than people want to let on. I think if we're being pragmatic about where this goes in the future, it's going to have to be the kind of models we think about. So thanks, Damion. It was really great to talk to you, and thanks for spending the time with us today.
No problem. Great speaking with you, and thank you for having me again.